Good morning. You are listening to Caregiver Crossing. It's a podcast brought to you by Joy's House, and we are so very blessed and thrilled that you're here with us today. Caregiver Crossing is a podcast created just for you, the caregiver. I'm Terri Stacy.
And I'm Joy Wallsten.
Joy is our producer, filling in for Tina this week. Well, family caregivers play a crucial role in the successful healthcare transitions of loved ones. They're uniquely capable of monitoring their loved one's progress and spotting red flags early on. They can also provide valuable information to physicians regarding disease progression, environmental changes, and other key details. Caregivers should be treated as partners in the medical care of their loved ones, but sadly, this is not always the case. Caregivers are often not involved in discharge and care transition planning processes, and they may not be adequately educated on their loved one's diagnosis, risk factors, or other essential information. And that failure to involve caregivers has high costs for everybody. So today we are joined by Regenstrief Institute Research Scientist, Dr. Kristin Levoy, who led a meta-analysis of finding from 54 studies involving more than 31,000 individuals, confirming that caregiver engagement across healthcare transitions of chronically ill adults is instrumental in preventing rehospitalizations and holds potential for enhancing other patient outcomes. And so I'm just so happy you're here, Dr. Levoy. Thank you for joining us this morning.
Oh, thanks for having me.
We are going to get right into this because we don't have a whole lot of time. So we'll start by asking, how can physicians more effectively involve caregivers in healthcare transitions?
Well, I think the simplest answer is first involving them in the first place. In this particular meta-analysis, we found that over half the interventions did not actively engage caregivers in the transition process. But beyond just engaging them in the first place, it's also thinking about the nature in which they're actually involved. And that can span across the spectrum of just sheer consultation with caregivers where they passively receive information, to involving them and gaining their perspectives on what is needed. And as you just mentioned at the top of the episode here is that caregivers are intimately knowledgeable of the challenges that they're experiencing at home and the challenges that patients have, the sort of hiccups that patients have had in their illness trajectories. And then finally, there's that another level of involvement, which is partnership and shared leadership, where really caregivers are involved with the healthcare team as co-creators of the patient's care plan. And so, in this, considering the spectrum, we looked at our studies that did involve caregivers, and the majority of studies did include caregivers in disease and self-management education, which is sort of that lower level of involvement of passively providing caregivers education. But that's not necessarily always enough. And then another about half of our studies involved our caregivers in sort of needs assessments and really trying to learn what their challenges are and whether or not the solutions and plan of care that they were designing for the patients was really feasible within their own personal and living circumstances. And very few studies really actively involve caregivers in that active co-creation of the care plan. And I think there's more room for that.
What kind of chronic illnesses were represented in the study?
There were a broad range of inclusion criteria across these studies. There were certain diagnoses that studies tended to focus on, which are more high risk chronic illnesses that often end up with frequent rehospitalizations. So that was cardiac disease like heart failure, someone that's had a recent heart attack, respiratory illnesses like chronic obstructive pulmonary disorder or COPD, pneumonias, patients who had recent strokes or chronic kidney disease. Beyond certain diagnostic groups, some of these studies were geared towards patients with multiple diagnoses. So they might have a co-occurring diabetes along with this other primary illness, or they might have other risk factors. They might be older adults with multiple home medications, so a complex medication management, or folks that had been hospitalized and received mechanical ventilation that also may put them at higher risk for rehospitalization. So it came in a combination of sort of disease groups and other varying risk factors.
What led to this study? How did we finally get here where we realized that caregivers were such an important and have been, but of late, why this study became so important?
I think that we've long sort of anecdotally realized how important caregivers are to improving the lives of their care partners or patients when they're dealing with chronic illnesses. And I think that this particular study was really wanting to understand their impact, specifically in the context of care transitions. So hospitals are now being held accountable for discharging patients and discharging patients and caregivers in a way after health crises where they're set up for success. And if they end up back in the hospital for that same condition, the hospitals are held accountable from sort of a financial standpoint. So this particular study, we know that care transitions interventions come with a variety of components, but we don't necessarily always know what are the active ingredients of these interventions that are truly improving outcomes. And this came from my own personal practice of just really understanding the value of caregivers. And so this study was really trying to, from an empirical standpoint, from a mathematical standpoint, say, yes, truly, caregivers are making a mark on patients' outcomes. And we need to think about how we more actively engage them in partners in care delivery.
Why are those transition periods so critical?
I think that, that's where breakdowns in care happen all the time following a health crisis, a hospitalization due to a health crisis. Often that results in new consulting physicians that patients may need to see post-discharge, a new specialist, maybe a change up in a primary care provider, a change in the medication management, and also extended amounts of ancillary services that patients may need, like home health to get physical therapy or occupational therapy or home health aides. But to the extent that, we have a really well-designed discharge plan, that's great, but then it's ensuring that it's executed. And I think that across those transitions, often things get missed and the ball gets dropped. So hospitals have sort of looked at designing transitional care interventions to avoid these pitfalls, to really truly make sure that the services that we wanted them to start up, like physical therapy, were actually initiated, that patients were set up with follow-up appointments with their primary care provider, that the new a plan around the patient's plan of care and their medication management were communicated across healthcare providers. And I think that's exceedingly difficult because patients that have multiple chronic conditions are often not only seeing their primary care provider, but maybe seeing 2 or 3 other specialists. So really everyone needs to be on the same page. So there needs to be some sort of centralized process for helping that to bridge that gap. And that's what transitional care is designed to do.
Do you know on average how many transitions that a patient might go through?
Yeah, the statistic we found when we were writing up the study is that patients after a healthcare crisis often experience anywhere from 2 to 5 healthcare transitions following a hospitalization. So if you think about someone that might have had a stroke, they may transition to another healthcare setting like a rehabilitation facility, and then a transition again to home. So that's 2 transitions right there. But if then complications are experienced, they may have another transition back into the hospital and back home. But across the course of a chronic illness, you can imagine that those number of accumulated transitions are quite substantial. And the sort of opportunities for these sort of pitfalls in care present themselves all the time. And really, caregivers are at the headwinds of all that, and making sure all the pieces, all the puzzle pieces are together. But I think there's a lot more that we can do from a healthcare system perspective to support them in that process.
What are some key ways that caregivers can support in interfacility transitions, not when a loved one is coming home from the hospital, but maybe when a loved one is transitioning from one facility to another?
Yeah, so this particular study looked at transitions from hospital to home primarily. But, when we're looking at inter-facility transitions, they are the primary advocates for patients and often are communicating the plan of care and bringing records to that facility and sort of closing the gap, some of these communication gaps between facilities. They're often there too from a safety standpoint and staying with the patient and sort of monitoring them at the bedside in these other facilities. So I think they definitely play a critical role. But when this particular study didn't necessarily narrow to that particular transition, it was more so transitions from hospital to home. But in any event, I think that what the findings show is that their engagement in that process really resulted in a significant reduction in the risk for rehospitalizations. Where among the studies that had that engagement, there was an 18% reduction in the overall risk for rehospitalizations.
That's great.
Yeah, and
that's something.
Absolutely. And I think that, I think, like I said before, I think anecdotally we recognize these things, but this provides some empirical support behind that. And among those studies that didn't have caregiver engagement, there was no overall significant effects on reductions in rehospitalizations. That really speaks to the power that caregivers have in improving patient outcomes.
Before we let you go, some of the barriers, let's talk just a little bit about some of the barriers that caregivers go through from getting that information and that support and accessibility they need. As you've seen, and you said yourself from your own experiences, it's getting better? Those barriers dropping, those barriers going down?
Patients, I think caregivers are really not always physically present at the time when some of this discharge planning is occurring. But that doesn't necessarily mean that they shouldn't be consulted. And this happened a lot in the COVID-19 pandemic where they weren't allowed physically in the healthcare setting. But we still need to be nimble and being able to reach out to those caregivers and involve them. And care is more and more siloed and fragmented, and it creates incredible challenges in sort of care coordination post-discharge. So I think healthcare systems, they're being held accountable. They are incentivized to make sure that these transitions go well. I don't know that we've necessarily figured out the best process for that, but healthcare systems are increasingly recognizing the need to have a formal transitional care model of care delivery, where there is a centralized person and hospital infrastructure to support those transitions and to support the scope of services that go along with that. I've personally worked with Dr. Mary Naylor, who developed a transitional care model that is a nurse practitioner-led transitional care model, where those nurse practitioners serve as a centralized person to really spearhead the process. They become a point person for both the patient and caregiver to contact across the transitions, but also become the spokesperson and advocate for those patients and caregivers among the various healthcare team members that are community-based. So I think there's a lot of momentum behind this. I think hospitals are still trying to understand what the best combination of services and which supportive personnel are best to spearhead these processes. But I think moving forward, there's going to be more and more support when it comes to transitional care for caregivers.
This study has been so important, and we loved having you with us today. I'm really grateful for your time. Joy, before we go, do you have any last questions?
So we've spoken a little bit about how hospitals have increased accountability for rehospitalizations. I was wondering if you could speak to what that term actually means. Is that when a patient returns to the hospital within a certain period of time? Is it when they return for the same exact ailment? Could you just elaborate on that?
Right. So the hospitals are being held accountable for certain diagnostic groups of patients that come in with a myocardial infarction or a heart attack, patients that come in with a flare in their heart failure or a flare in their COPD. They are held accountable such that following discharge, if they end up within back in the hospital within a 30, 60, or 90-day period following that hospitalization, the the hospital becomes accountable for a portion of those services, and that because they didn't set this stage for success, they have to bear the costs of that sort of episode of care. So hospitals are sort of incentivized to make sure that we are setting the stage so that patients aren't coming back into the hospital. And this particular study looked at all-cause rehospitalizations, which could be a rehospitalization for any purpose and not necessarily related to the inciting event. And we did that because it was the most commonly reported outcome across studies. So it gave us a little more statistical power to understand our research questions. But I think in future studies, we could drill down towards rehospitalizations that are specific to the original hospitalization or the reason for admission, and also its influence on even just ED visits that don't necessarily end up resulting in an admission.
Thank you. Thank you so much. Dr. Kristin Levoy with Regenstrief Institute. She's a research scientist there, and we are really grateful for the work that you do. And I hope you'll come back and see us. Thank you so much for joining us today.
Thanks to you both.
As we close the show, we just want to remind our listeners that they can contact Tina McIntosh, who will be with us next time. If you need to get in touch with her for information or resources to help you through the journey of caregiving, you can send her a note at tina@joycehouse.org. We also want to thank our supporters, Cardon and Associates, with 20 communities owned, operated, or managed in the Midwest and more than 40 years of senior living experience. Cardon and Associates provides residents with the best senior living options and personalized service. We also want to thank Kat Sapper and Miller. KSM is a leading advisory, tax, and audit firm providing the inspiration, insight, and technical expertise you need. Severance and Howard, the attorneys at Severance and Howard are dedicated to working together with families to develop comprehensive care plans that ensure you and your loved ones are protected for your immediate and future needs.